Lefere, you're muted.
Hello, hi, good afternoon. Thank you to be present, and it's my pleasure to open this webinar. It's part of the educational events organized by ESPGHAN. It is particularly my pleasure to chair this webinar. Elvira Verducci. I'm the chair of the Childhood Obesity Special Interest Group under the umbrella of the Committee on Nutrition. And this event is organized with the collaboration of the Fatty Liver Special Interest Group led by Claudia Mandato. The topic of this webinar is focused on pediatric liver disease, genetics, and nutrition. We will have four speakers, sorry, and we will speak about the diagnostic tools and the diagnosis related to muscle in pediatric age, and two speakers that will focus on the dietary intervention and the use of the bioactive compounds in muscle. And the last speaker will focus specifically on the Wilson disease, because one of the topics of this webinar is also the pediatric liver disease related to genetic alteration. And so at the end, obviously, we will open the discussion, and it's a very, again, a pleasure to introduce Claudia Mandato that will chair with me this webinar.
Thank you. Thank you so much, Elvira. Good afternoon, everyone. It's a great pleasure to chair today's session together with you and focusing on this highly relevant and evolving topic. I think we can start with the first speaker. Dr. Sander Lefere is a clinician and a scientist from Ghent University, and with a recognized expertise in the metabolic liver disease and on muscle D. And his work focuses on the non-invasive diagnostic tools, pathophysiology, and translation aspect of fatty liver disease. So I'm very glad to invite him to start his presentation. Thank you, Sander.
Thank you, Claudia and Elvira, for the kind introduction and the kind invitation. Can you see my screen? Yes.
Yes.
Yeah. Okay. Perfect. Yeah. So thanks again also to ESPGHAN for inviting me. As Claudia mentioned, I will mostly discuss diagnosis and also a little bit risk stratification of pediatric muscle D. So muscle D, or metabolic dysfunction associated steatotic liver disease. So if you want to talk about diagnosis, of course, we need to know what the definition of the disease is. And this has changed in recent years. We moved on from the term NAFLD to the diagnosis MASLD, although in practice, most of the patients or the patient groups overlap nearly completely. But this is important because we moved from a so-called negative diagnosis, telling what it is not, non-alcoholic, which did not make much sense in pediatrics any case, to a more positive diagnosis of metabolic dysfunction associated, which describes what the disease is all about. So the flowchart seems perhaps a bit complicated, but first of all, if we want to diagnose MASLD, we need, of course, to demonstrate steatotic liver disease. So we need to demonstrate liver steatosis. If there are no red flags, I will discuss in a minute, then we have to see if the patient meets any cardiometabolic criteria. And specifically for children, it's important that we should mostly only diagnose MASLD in case children have overweight or obesity. And they can, of course, have other comorbidities, aspects of the metabolic syndrome, such as hyperglycemia, hypertension, hyperlipidemia, low HDL cholesterol, which point towards the metabolic dysfunction. So if the patient meets these criteria, then we can diagnose MASLD, but we should also be mindful of excluding alternative diagnoses because, of course, MASLD can coexist with other liver diseases as well. And indeed, with the ESPGHAN MASLD special interest group, we are writing a position paper which is nearly published. I was hoping to be able to show you the published publication, but we are not there yet, just yet. Still, this is a table from this position paper, and so if we make a diagnosis of MASLD, we also recommend excluding other diagnoses with specific investigations, such as doing a liver ultrasound, doing, of course, routine biochemistry, but also doing determining circulating immunoglobulins, antinuclear antibodies, ceruloplasmin, thyroid function tests, and so on, excluding viral hepatitis, excluding Wilson's disease. Of course, Emmanuele will talk about this in more detail afterwards, but it is also very important that we never lose sight of this if we also diagnose MASLD. Then we should also be mindful of particular red flags. So very young children, they can have MASLD, but the younger they are, the more likely an alternative diagnosis could be. If there are very high liver tests, usually MASLD doesn't present with liver tests of ALTs above 150. Of course, if there is already signs of advanced liver disease, or if MASLD is in a spectrum of syndromic features of developmental delay, then for sure these are red flags, meaning that we need to refer these patients to a pediatric liver specialist for more intensive diagnosis. So if we talk about diagnosis of pediatric MASLD, we actually have quite different diagnostic tools available. We have liver biochemistry, such as ALT values. We can calculate risk scores, which are often based on a combination of liver biochemistry with, for instance, anthropometric values such as body weight or waist circumference, and perhaps also markers of insulin resistance or hypertension, for instance. And these can, in a combination, tell us something about the likelihood of, for instance, more severe liver disease. We have imaging tools, and lastly, we also have liver biopsy. And I will first say some small words about liver biopsy. It's still the gold standard tool for diagnosis and staging of liver disease in MASLD as well. It's very useful to exclude alternative diagnoses at the same time. However, of course, with the high number of patients with MASLD, it is not feasible and also certainly not desirable to do an invasive investigation in all of the patients. And that is why it's mostly reserved for specific cases of diagnostic uncertainty, with cases that are perhaps less typical, or already patients who have signs of advanced liver disease. And then there is also discussion if it could be useful in adolescents to do a liver biopsy to facilitate transfer to transition to adult care. If we want to, and this is perhaps especially for the future, if we want to initiate drug treatments, that maybe we want a baseline liver biopsy. And especially in the setting of clinical trials, of course, then a liver biopsy is more often performed to be able to assess the effects of treatment. On the biopsy, we are able to visualize liver steatosis, but also inflammation and ballooning, so the hallmarks of steatohepatitis, and we are able to accurately stage liver fibrosis. So these are a lot of upsides. Of course, this is an invasive investigation that we really want to avoid as much as possible because of the risk of complications. And so for the rest of my talk, I will mainly focus on non-invasive diagnostic tools that we use more in standard clinical practice. First of all, and perhaps most well known, is ALT, because a raised ALT value can point towards liver disease, be it MASLD, be it any other kind of liver disease, but it's well known that a lot of children with MASLD have elevated ALT levels. For this, it's also important to note that there are sex-specific cutoffs that we can use in children, and that these cutoffs are quite low. For instance, in US cohorts, they're typically 26 units per liter for boys and 22 for girls. So these are lower than what is often reported in your biochemistry as the reference values. Still, depending on the cutoffs that you use, ALT either has a low sensitivity or a low specificity, and meaning that it's also not an ideal diagnostic tool of itself. And for instance, we did a study a couple of years ago in a tertiary setting of an obesity cohort. We had almost 350 children, And for instance, there were 76 children with steatosis on ultrasound, but who had a low ALT. So in these children, we would miss the diagnosis, and a low ALT alone perhaps could give us a false sense of reassurance. And indeed, further in this cohort, you can see that, okay, children without steatosis, they generally had a low ALT levels. Children with severe steatosis on ultrasound, they had elevated ALT levels. But then the patients in the middle with mild to moderate steatosis, some of them had elevated ALT levels, others not. So ALT alone is not perhaps the perfect tool, but is of course widely available. It is cheap. And an upside is that you can, of course, repeat the examination over time. So also you get information on the dynamics. There are also some studies suggesting that the level of ALT also correlates with disease activity. And then, for instance, cutoffs of 80 denote a higher risk of more advanced liver disease. So especially if you have patients with an ALT, for instance, above twice the upper limit of normal or above 80 units per liter, these are patients that you would want to work up in more detail and follow up more closely. And then there are also interesting data again from the US showing that the evolution of ALT and gamma GT over time also gives important information. If you have patients with baseline elevated ALT and the ALT decreases after lifestyle intervention, that this correlates actually quite well with histological improvement. So perhaps more useful than a single ALT measure is the dynamic course of ALT over time. So that's for ALT. A second category of diagnostic tools are the so-called fibrosis risk scores. As the name says, there are some tools for steatosis, but they are especially for the diagnosis of fibrosis, which is also prognostically important, as well as in children and in adults. And most of these scores make use of a combination of body weight measures, perhaps ALT, perhaps other lab values, perhaps values reflecting metabolic dysregulation to try to accurately assess the risk of fibrosis in children. That being said, there's been this is a study from our special interest group led by the colleagues from Berlin a couple of years ago, and they basically collected data from all over Europe, more than 450 patients, and looked at the accuracy of all the risk scores that have been used in clinical practice. And unfortunately, none of the risk scores were accurate, and even none of them outperformed the single measurement of ALT. This is also shown here in the data table from this paper. So ALT had an area under the curve for prediction of MASLD with moderate or worse fibrosis of 0.6. And to give you an idea, this translates into a sensitivity of 67% and a specificity below 50%. So this is really not an accurate tool. But all the other tools that were investigated, APRI, FIB4, PNFI, they did not perform better than ALT alone. So there is a gap here in what we can use in the clinic. And that is why some new tools have been developed. This is a tool that we have developed and then validated in some European cohorts, based again on, in this case, sex, ethnicity, weight Z scores, HOMA-IR for insulin resistance, ALT, and presence of hypertension. And then our colleagues from the US have also developed their own score based on, I think, no less than 17 clinical variables that you have to put into a calculator. And then again, you also get a score that should, with more accuracy, determine if the patient has at least moderate liver fibrosis. So these are perhaps promising tools, but they need more validation, I think, before we can use them in routine clinical care. And then with this, I move on to a diagnosis of, imaging tools, and start with liver ultrasound, which is of course widely available. You can use it for diagnosis of liver steatosis, and at the same time, it can be useful to have an idea for the exclusion of other causes of liver disease. And there are several also semi-quantitative scores available, such as this one, which is very easy, that tries to standardize the diagnosis of steatosis a little bit more based on the echogenicity of the liver vis-a-vis the kidney and the visibility of the diaphragm and the intrahepatic blood vessels. And this allows us to still in a somewhat subjective way, of course, but to categorize patients as having mild, moderate, or more severe steatosis. Next, we also have imaging for the diagnosis and staging of liver fibrosis. Perhaps most well known is transient elastography or FibroScan, shown here. The advantage is that we now also have, next to the medium probes, we also have XL probes for patients with obesity, and we have small probes for children, for very small children. And the idea is that FibroScan measures the physical stiffness of the liver, and the stiffness then correlates with the degree of liver fibrosis. So the higher the FibroScan, the more stiff the liver is, the more liver fibrosis. Still, there's a lot of discussion in the pediatric literature how accurate this tool is for diagnosis, and this is in big contrast to the adult field. Well, there are literally hundreds of studies showing that FibroScan correlates very well with fibrosis in adults. In children, we are not there yet. We also have very little idea about the good cutoffs that we want to use. For instance, for severe fibrosis, do you need to use 8, 9, 9.5 kilopascals? So this is a big debate. Several centers don't really believe in FibroScan. My personal opinion, and I guess this is just a personal opinion, is that it works very well in adults, and at least for older adolescents, this is just a physical measurement of a stiffness. So I don't see a reason why this should not work in older adolescents. Of course, in young children, you have a different physiognomy and so on, but as a physical measurement, I still very much believe in FibroScan. There are also other techniques such as shear wave elastography, which are built into ultrasound machines, but there are even less data on this in children. So again, we have no ideas about specific cutoffs that we can use in clinical practice. And then lastly, there is MR elastography, which is very accurate, but of course in routine care, not widely available and is mostly reserved for clinical studies. Lastly, we also have controlled attenuation parameter, which is a modality on the FibroScan device, and this correlates with the degree of liver steatosis. As you see here on the graph, the more severe liver steatosis is on histology, the higher CAP values are. But again, just as for FibroScan, there's also an ongoing debate about which cutoffs can we use to diagnose liver steatosis based on CAP values. And then this is just an excerpt from data from a study that we performed. Again, we see a good correlation between steatosis on ultrasound and CAP values, but you can also see that there is quite a bit of overlap between the groups. So none of these tools is very perfect. So this is just an overview that I gave about the diagnostic tools. If you want to use this in clinical practice, for instance, for screening, where does this leave us? I won't go into this table in very much detail, but both the American recent guidelines as well as our upcoming position paper actually recommend serum ALT as a first-line screening tool if you want to screen children with obesity or with overweight and risk factors for MASLD. And then if ALTs are elevated, then we would recommend doing an ultrasound to also demonstrate the presence of steatosis itself. And lastly, we have a lot of diagnostic tools. So how do we integrate them to risk stratified patients? How do we compare if we have different tools with maybe different results? But unfortunately, this is still a matter of expert opinion. There is very little data on this available. And that is also why in a recent study with some people from different European centers, we tried to design a flowchart. Again, this is just expert opinion. We want to prospectively validate this, but we would propose that we perhaps aim to risk stratify patients into low, intermediate, and high risk based on ALT levels, but also based on FibroScan values and on these new fibrosis risk scores. And the higher the scores are, the lower the barrier should be for referral to a pediatric MASLD expert and to start more intensive treatment. So to summarize my talk, on screening, ALT is recommended by societies as a screening tool, and follow-up is then with imaging to diagnose the steatosis itself. For diagnosis, We've shown that simple risk scores are not very accurate, the ones that are available in clinical practice. If available, I think FibroScan is a good diagnostic tool, but there is still discussion on which cutoffs that we should use. Liver biopsy is reserved mainly for cases of diagnostic uncertainty. And how to integrate all these various tools into a diagnostic algorithm is still a topic of active debate. And of course, just reminding that it's very important to also exclude other liver diseases if we make a diagnosis of pediatric MASLD. So with this, I'd like to thank you for your attention and would be happy to answer any questions after all the talks.
Thank you so much, Sander. Thank you for the great presentation, and it was very clear. And at the end of the discussion. And now is my pleasure to introduce Giulia Fiore and Judit Munoz that will speak about the dietary intervention in bioactive compounds and their role in MASLD. Giulia is a nutritionist and a postdoctoral researcher at the University of Milan, and Judith is a nutritionist and a postdoctoral researcher at the Paediatric Unit at the University of Reus in Spain. And both are members of the Child Obesity Special Interest Group and are very active in our SIG. Thank you.
Do you see my screen?
Yes, yes.
Okay, perfect. So let's practically speak about dietary intervention and bioactive compounds, or which is the role in MASLD. And specifically, if we have to speak about dietary intervention in MASLD, we should, of course, not disregard what are the gold standards for obesity treatment. As we have already seen, this condition of MASLD, of course, specifically, it's highly associated with obesity in pediatrics. So, of course, the guidelines and the gold standard for obesity should not be disregarded. And what are the gold standard approaches? Of course, are integrated approaches looking not only at diet per se, but also at physical activity, psychological health. So this is called multi-component intervention, and this multi-component intervention should include the family and a behavioral change. And talking about therapy goals that should be reached during the treatment is achieving a balance between energy expenditure and calorie intake, of course, in the children, but also, meanwhile, maintaining an appropriate growth. So we should be conservative and preserve linear growth of the children. That's why when we deal with dietary approach in pediatric age, we should not be that restrictive, because we can highly impact linear growth. So meanwhile, preserving growth, maybe we want to follow we want to reduce the excess weight. It's not the case every time. So we have to be reminded that it depends on the direct and personal intervention we want to follow. And sometimes we want to change let's say, change the body composition by reducing fat mass and enhancing the active muscle mass. And all of this should be done preserving the psychological health, because we are speaking with the children, so they are extremely vulnerable, and we should not be impactful on what is the relation with the health, with the diet and the food. So we have to be reminded that every data intervention is very important, also in terms of health and food relation, let's say. And lastly, we want to improve any comorbidities, but the final goal is achieving and maintaining the changes observed in a long-term follow-up. And we know that for obesity, pediatric obesity, there are targeted dietary strategies according to different comorbidities. So we know that in case of alteration in glucose metabolism, we should go and prefer low glycemic index, low glycemic load diet. Or in case of alteration in blood pressure, there is the DASH diet, which is known as dietary approach to stop hypertension. What to do in case of muscle D? Well, we are working with the SIG on fatty liver to try to define a consensus on the dietary treatment, because nowadays there is not unique guidelines defining what is the real dietary intervention. Of course, lifestyle interventions, so diet and exercise modification, are the first treatment option for muscle D in children. So we know this. There is meta-analysis showing that diet and lifestyle are the, of course, target therapy and the first-line therapy. What is this diet and this physical activity practically? What are the evidence from the literature? So there is quite heterogeneity among studies in the literature. For example, if we look at physical activity, usually aerobic workouts are the one recommended, but the session and the amount of time might be very different among studies. But usually regarding dietary approach, we deal with balanced diet. So this is the standard approach and the best evidence on this. And the interesting part is that a combination of physical activity and dietary approach really impacts on steatosis risk reduction, and in a 61% risk reduction. Of course, in these cases, in this meta-analysis, the evidence was based on radiological, histological evidence is heterogeneous. So regarding specifically physical activity, because it's part of our lifestyle intervention, in children with muscle D, both aerobic and resistant training in a vigorous or moderate to vigorous intensities can reduce hepatic fat. And the best optimal exercise should be a 60-minute session at least. So the volume is 60 minutes with a frequency of three session weeks. Let's so now deal with the dietary strategy per se. And when we speak about dietary strategy in muscle D, there is 4 different layers of intervention. So the first layer is dietary pattern, and there is also non-restrictive approach, but there is also restrictive approach and specific nutrient reduction and supplements. Dietary pattern, the most studied dietary pattern in children with muscle D is Mediterranean diet. Apart from the very well-known, let's say, healthy aspects associated with the Mediterranean diet, Med diet is particularly studied for the high intake of fiber and paralleled by a high intake of omega-3 from the diet and antioxidants included in this pattern. So, specifically, randomized controlled trial studying the effect of adopting a Mediterranean diet compared to a normocaloric low-fat diet. So both the intervention are dealing just with the quality of food offered, not with the calorie per se of the diet. So both the intervention have the same amount in terms of calories, but the quality of food offered are different. And it's interesting that MAD diet was significantly higher. With the MAD diet, the decrease in AST was higher, and also the decrease observed in ALT was greater in the MAD diet, although not reaching statistical significance. And also, MAD diet shows additional benefit in reducing oxidative stress. And that's why after this randomized controlled trial, there was also a systematic review and meta-analysis published specifically addressing children adopting the Mediterranean diet compared to standard or low-fat diet. And the evidence is that Mediterranean diet is associated with moderate improvements in liver function. Of course, they just look as a primary outcome to liver enzymes, but this is a starting point. So when we have to deal with a dietary intervention with children, we should look for a dietary pattern. Then there is a non-restrictive approach. Non-restrictive approach, we refer to counseling to families. And with this counseling, we ask families to reduce, for example, consumption of sugar-sweetened beverages, or change unhealthy behaviors like skipping breakfast. And there are other non-restrictive approach, like, for example, the traffic light or modified traffic light diets, in which, for example, you can help the family understand the energy-dense food control and encourage healthy eating patterns, just looking at these infographics with colors. And the red color is eat only once or twice a month, while the yellow is eat only once or twice a week. And daily eating is red, is of course green. And similarly, is the infographic based on the low glycemic index and low glycemic load diets, which are focusing instead on the glycemic index of foods, but practically speaking, it's giving and addressing the quality of foods with the family during the count. In some cases, however, it's necessary to follow a restrictive approach, and to follow a low-calorie diet might be necessary. So in this case, we should follow a balanced low-calorie diet with a 30% reduction in the estimated energy intake, or a 15% reduction in daily energy requirements can be followed. When I say balanced, I mean that should be like 45 to 60% energy from carbohydrates, 10 to 15 from proteins, and 20 to 35 from lipids. While we know from dietary treatment in obesity, in children with obesity, that low-calorie, high-protein diets or low-calorie, hyperlipidec diets are not recommended at all, and they are not educational for the family and the children. What we can say about the very low-calorie ketogenic diet, we know that in obesity, is not recommended for school-age children, as this is very restrictive approach and should be followed for a very short period. Sometimes it can be considered in children, in adolescents with comorbidities or candidates to bariatric surgery. But what is the evidence in MASLD? Actually, there is no evidence. There is just one pilot study, and it's on adult population. So we should study a lot much more this standard approach before taking this into account in a pediatric population with MASLD. Even though in the pilot study there was some, of course, amelioration and a reduction in liver fat accumulation. And the last target for dietary treatment is specific nutrients reduction, and this is the case of sugars that have been investigated a lot over the last years. And this is a very interesting JAMA study. It's a randomized clinical trial in which 40 adolescents were enrolled for 8 weeks, and 20 adolescents followed a diet with the low free sugar content, which means less than 3% of total energy intake from sugars, and another group followed the usual diet. And after 8 weeks, what is really interesting is that there was a mean decrease in hepatic steatosis assessed with the MRI-PDFF. And the important part is that no changes in calorie intake were adopted, no changes in either in physical activity. So the only change that occurred in these 8 weeks were just low free sugars. So just by reducing low free sugar, the effect on hepatic steatosis was significant and clinically impactful. The same authors also studied de novo lipogenesis, and also this was confirmed and reduced in the low free sugar group. So the final question that we want to brought here is that restricting low free sugars means probably in our diet restricting the consumption of sugar sweetened beverages, because free sugars in many cases comes from the consumption of sugar sweetened beverages, and we know that these products are really rich in fructose. So the question is also fructose the real nutrients that has been reduced, and this is the real effect that is coming from the diet. So the reduction of fructose probably, but we have to study this into detail still, and there is no real evidence whether it's sugars in total or fructose per se. So to summarize, what is dietary strategies and what are the most effective we should follow in MASLD, pediatric MASLD? Of course, reduce free sugars, and this is quite a strong evidence. Improve overall diet quality, and if we can follow a Mediterranean dietary pattern, it's the best, achieve energy balance, and when necessary, a weight reduction can be followed. And lastly, ensure long-term adherence. So change in the dietary habits should be long-term, and that's why we suggest family-based and behavioral approaches. Lastly, we can also try to complement our dietary strategies with other strategies, complementary ones. And this is the case of supplements and bioactive compounds. And now I pass it's the time to Judit. So I let her share the screen.
Okay, thank you, Giulia. Did you see my screen?
Yes.
Thank you.
Yeah.
Okay, so as Giulia has shown you the dietary strategies for pediatric muscle, and now we're moving to other strategies that recent evidence suggests that may have also beneficial effects on several outcomes, including liver enzymes, hepatic steatosis, and metabolic parameters, which are the bioactive compounds. I will briefly go through the main ones that have been studied in pediatric muscle, including omega-3 fatty acids, vitamin E, vitamin D, and probiotics. So starting with omega-3 fatty acids, they have been proposed to exert beneficial effects in muscle D through multiple mechanisms by decreasing lipogenesis and improving inflammation. They also may influence adipose tissue metabolism and potentially modulate the gut microbiota. Overall, the results is reduced hepatic steatosis and inflammation. To better understand the clinical effects of omega-3 fatty acids, we can see these meta-analyses, including 378 participants receiving either omega-3 supplementation or placebo. The duration of the interventions range from approximately 24 weeks up to 24 months. However, it's important to highlight that there is a considerable heterogeneity across the studies in terms of dosage duration and the study design. Looking at the results, omega-3 supplementation was associated with a statistically significant reduction in ALT and AST levels. Some studies also reported a decrease in the BMI, and importantly, were also associated with an improvement in the degree of hepatic steatosis assessed by the ultrasonography. Overall, these findings suggest a potential beneficial effect of omega-3 fatty acids on liver enzymes and steatosis. In addition, this network meta-analysis led by Theodoris, that we will see this, the results of this meta-analysis in every bioactive compounds that I will show you. They have explored the comparative efficacy of different interventions. And an important finding is that the beneficial effect of omega-3 on ALT appears only when it's combined with a lifestyle intervention. Moving now to another bioactive compound, vitamin E, which has been studied mainly for its antioxidant effects. It may reduce oxidative stress, inflammation, and hepatocyte injury. So there is a strong biological rationale for its potential role in muscle D. When we look at the clinical evidence, several studies have evaluated the role of vitamin E in pediatric muscle D. However, the results are quite inconsistent. In many cases, there is an improvement in liver enzymes and histological features, but these changes are often not significantly different compared to lifestyle intervention alone or with placebo. This variability is also reflected in meta-analysis. Overall, vitamin E may improve some metabolic parameters, particularly lipid profile. However, its effects on liver function, and especially on liver histology, is not clearly demonstrated. In addition, only a few studies have assessed outcomes such as the NAS score, which limits the strength of this evidence. And similar findings are observed when comparing different treatment strategies. If we look again at this network meta-analysis, vitamin E alone does not show significant effect compared to other interventions. In fact, the most favorable results are observed when vitamin E is combined with lifestyle interventions or with other plus other compounds than with other compounds only. And this again makes it difficult to isolate its independent effect and suggest that vitamin E on its own may have limited clinical impact. So overall, despite a strong biological rationale behind the use of vitamin E, the current evidence does not support a clear and consistent benefit in vitamin E in pediatric muscle D. Then we have vitamin D, which has gained attention in the last years in pediatric muscle D, mainly because its deficiency is very common in children with obesity. From a mechanistic perspective, vitamin D may influence several key pathways involved in the progression of this disease. It has been linked with to regulation of lipid metabolism, inflammation, and fibrosis. So overall, again, there is a strong biological rationale for its potential role in the muscle D. But the key question is whether this translates into clinical benefit. First, I wanted to show you this meta-analysis in which, similar to what we often see in obesity, children with muscle D also tend to have lower vitamin D levels. However, this is only an association and does not imply causality. So, while vitamin D deficiency is common in these patients, it remains unclear whether it plays a direct role in the development of this disease or simply reflects underlying metabolic dysfunctions. So the next question is whether vitamin D supplementation can actually improve clinical outcomes. This randomized controlled trial evaluated the effect of vitamin D supplementation in children with vitamin D deficiency, obesity, and muscle D. And patients received either vitamin D or placebo during 6 months, and both groups also follow an hypocaloric diet. Group U is the one you have in the left, is the one who received vitamin D supplementation, and group 2, the one in the right, received the placebo. In this table, we can see that after 6 months, vitamin D supplementation was associated with an improvement in several parameters, including liver enzymes, lipid markers, and insulin-resistant markers. Here, sorry. Compared with baseline and compared with the placebo group. And in contrast, the placebo group showed no significant changes in any parameter. In addition, there was also improvement in hepatic steatosis and inflammation, reflected in changes in histological scores, such as the NAS score, compared with baseline and with the placebo group. However, the results should be interpreted with caution, as the intervention was combined with dietary changes, making it difficult to isolate the effect of vitamin D. For this reason, the authors recommended vitamin D supplementation as an adjuvant treatment together with lifestyle modifications. In addition to vitamin D alone, some studies have evaluated combined interventions, such as vitamin D together with DHA. In this study, participants received DHA plus vitamin D for 12 months, and the results in the left part of the table show improvement in several histological features, including steatosis, ballooning, and inflammation, as well as a significant reduction in the NAS score. Then these results were compared with others from a previous study with a supplementation of only DHA. It was with a different population, but also in children. And we can see that the results are very similar, with significant improvement in the same parameters, steatosis, ballooning, inflammation, and also in the NAS score. Therefore, it is difficult to determine whether vitamin D provides any additional benefit that other compounds, such as DHA in this case. Finally, looking at this network meta-analysis from Theodoris, vitamin D does not show a strong or consistent effect when compared across different treatment strategies. Some benefit may be suggested, particularly in children with vitamin D deficiency, but the overall evidence remains limited. And importantly, as with other bioactive compounds, the most favorable results are generally observed when vitamin D is combined with lifestyle intervention rather than used alone. So overall, as we have seen until now, bioactive compounds show some potential benefits in pediatric muscle D, particularly in improving liver enzymes, steatosis, and metabolic parameters. However, the available evidence is limited by small sample size and high heterogeneity, especially in pediatric population. In addition, most studies combine these compounds with lifestyle interventions, making it difficult to isolate their independent effects. Therefore, at this stage, they may be considered as an adjunctive strategy, but they should not replace lifestyle intervention and are not recommended for routine use. and also more studies are needed in pediatric population. Finally, I will move to the last part of this presentation, focusing on the potential role of probiotics in pediatric muscle D. We know that alterations in gut microbiota may contribute to the progression of this disease, but also they represent a potential therapeutic target, which is the rationale behind the use of probiotics in patients with muscle D. When looking at the available evidence on microbiota modulation, we can see that there is a relatively large number of studies, including prebiotics, probiotics, and symbiotics. However, an important limitation is the high heterogeneity across these studies. Different interventions with different probiotic strains, combination of strains, and even mixtures with other compounds such as vitamins. This makes comparisons really difficult. And in pediatric population, the available data is even more limited. Looking at the available evidence, this meta-analysis evaluated the effect of probiotics in pediatric muscle D. Overall, probiotic supplementation was associated with improvements in liver enzymes, particularly ALT, as well as in BMI, waist circumference, total cholesterol, and triglycerides. However, an important point to consider is the variability in the strains included, such as lactobacillus or bifidobacterium, or the BSL3, which is a patent including lactobacillus, bifidobacterium, and streptococcus. As highlighted in the conclusion of this meta-analysis, probiotic supplementation may have beneficial effects in children with muscle D, but due to the wide variety of strains and combinations used across the studies, it is not possible to identify a specific probiotic or formulation that is clearly superior to the others. Here, for example, we can see different clinical trials using very different products, doses, duration, and even combination with also lifestyle intervention or physical activity. And even some studies use single strains, others use mixtures like the BSL3 we have just commented, which is a mixture of 8 different probiotic strains, or ProKit or BioCult, that are also another patents, including 4 and 14 different strains, respectively, and sometimes also combined with prebiotics. Prebiotics. So at the end, we are not comparing probiotic as a single intervention, but very complex and very different combination, and this makes this extremely challenging to identify which specific strains, combinations, or doses are actually responsible for the observed effects. If we look again for the last time of this network meta-analysis from Theodoris, probiotics also appear. As we can see here, the evidence is still quite limited, and the effect size are relatively modest. Importantly, this potential benefit is mainly observed when probiotics are used in combination again with lifestyle interventions. And as we have discussed, this category includes very heterogeneous interventions and strains. So, to summarize the available evidence on probiotics in pediatric muscle D, probiotics may have some potential beneficial effects, particularly in improving liver enzymes and possibly some metabolic parameters. However, the results should be interpreted with caution, as the evidence is still limited and highly heterogeneous. And importantly, most of the observed benefits occur when probiotics are used in combination with lifestyle interventions. So, as the other bioactive compounds seen before, probiotics may be considered as an adjunctive strategy. Finally, I wanted to show you this recent meta-analysis, which compared different treatment strategies for pediatric muscle D. They found that ALT and AST levels were significantly reduced, influenced by diet, lifestyle, and supplements, such as vitamin D, DHA, or probiotics. And also, there was an improvement in the cardiometabolic risk parameters, including the BMI and the insulin resistance index. However, the main conclusion of this meta-analysis was that while some of these strategies may offer additional benefits, the evidence is limited and very heterogeneous. So they may be considered as an adjunctive option for children with muscle D. Considering the limited and heterogeneous evidence regarding the role of bioactive compounds in the management of obesity and its associated comorbidities, including the muscle D, as Giulia mentioned at the beginning of our talk, Our group in the ESPGHAN, the Childhood Obesity SIG, in collaboration with the Fatty Liver SIG and the Committee of Nutrition, are currently conducting a position paper with a network meta-analysis on this topic. So we hope to contribute to this field with more robust evidence, and we look forward to sharing new and interesting results with you very soon. To conclude, lifestyle interventions remain the cornerstone of treatment in pediatric muscularity, with clear evidence supporting the role of both dietary modifications and physical activity. In particular, dietary patterns such as the Mediterranean diet, as well as normocaloric, low glycemic index, and low free sugar approaches appear to be beneficial when combined with regular exercise. And finally, bioactive compounds, including omega-3 fatty acids, vitamin D and E, and probiotics, may have a role as complementary strategies. And thank you very much for your attention, and we are happy to answer your questions at the end.
Thank you so much, Giulia and Judith, for your complete and nice presentations. So we can move to our final speaker. It's a pleasure to introduce Professor Emmanuele Nicastro from University of Insubria in Italy. Professor Nicastro is a member of ESPGHAN Hepatology Committee. He is a great expert in pediatric hepatology and with a particular expertise in inherited liver disease, including Wilson disease. Is a co-author of the last guideline published on Wilson disease. And now today we'll present Wilson disease from diagnosis to treatment. It is very important because Wilson disease is behind the muscle D, so we need to be sure that Wilson disease is ruled out when we treat children with muscle D in clinical practice. Thank you, Emmanuele. Welcome.
Thank you, Claudia. I hope that everyone can see my screen.
Yes.
I will try to stay quite light. And I just connect to what presented by Sander. We know that actually in presence of cardiometabolic criteria, we have to look for other etiology in pediatric steatotic liver disease, performing some first-line investigation, attempting to exclude with enough certainty autoimmune liver disease, Wilson's disease, which is the topic of the talk, and also other causes like celiac disease, alpha-1 antitrypsin deficiency, and viral hepatitis. But when the approach changes in presence of red flags, as Sander mentioned before, when these conditions are present, we have to perform extended investigation when the child is actually too young, too lean, or too sick. And this diagnostic workup is complex and includes investigation aimed at identifying inborn error of metabolism associated with accumulation of toxic metabolites, like defect in carbohydrate metabolism, such as hereditary fructose intolerance or glycogen storage disease, amino acid defects such as tyrosinemia type 1 or organic acidemias, and also lipid disorder like peroxisomal defects or fatty acid oxidation defect, but also other lipid trafficking defects such as lysosomal acid lipase deficiency. And you can see that apart from endocrine and nutritional causes, the vast majority of these rare causes of pediatric steatotic liver disease are monogenic disease. That's why there is an increasingly widespread approach of performing genetic testing using massive parallel sequencing in children who present with specific phenotypic features. This includes a positive family history, inconsistency with cardiometabolic criteria, very young age, liver disease with impaired synthetic function or a rye-like phenotype, and the presence of extrahepatic, especially neurological or muscular involvement. In these cases, a next-generation sequencing approach may be appropriate as it provides a meaningful diagnostic yield with reducing diagnostic time and costs. Now, let us move closer to the main topics of this talk, because conversely, in a child, for example, older than 10, with clear cardiometabolic criteria, muscle D can be diagnosed easily, provided that autoimmune hepatitis and Wilson's disease are excluded. Focusing on Wilson's disease, the diagnostic criteria include low ceruloplasmin levels below 20, increased urinary copper excretion, even values above 40 microgram per liter are meaningful, and more recently, elevated levels of free plasma copper measured with advanced techniques. I would like to introduce this topic through a clinical case that will guide us throughout the discussion. This is the case of Tamara, a 13-year-old girl who presents to the emergency department with the onset of sudden involuntary limb movements, myoclonus, and dizziness. Tamara is overweight with a BMI of 23.9 and a Z-score of 1.27. She go to the psychiatric evaluation. Her family history was remarkable, except from an older brother with autism spectrum disorder. Her personal history revealed that about 1 year earlier, she had mild hypertransaminesemia around 60 in the context of being overweight. Following dietary and lifestyle recommendation, there was an improvement with a reduction in both excess weight and transaminase levels. The patient also had a history of anxiety related to school performance. The psychiatry team, where the patient was admitted, considers her transaminase level to be within the normal range, as is the rest of her organ function. Extended autoimmune and rheumatologic screening is negative, and as is urinary porphyrin testing. However, ceruloplasmin levels are markedly low, and liver ultrasound shows increased echogenicity. The neurological picture rapidly improves spontaneously with the resolution of the abnormal movements, and in the following hours, the patient experiences panic attacks, and psychological assessment reveals significant school-related and social anxiety. This clinical scenario, together with a normal brain MRI, supports a non-organic cause for her neurological symptoms. However, the patient is referred to us due to the presence of hepatic steatosis, hypoceruloplasminemia, and the border transaminase levels in an overweight girl. I will spare you the details of the investigation performed to exclude other common causes of liver disease, and I will focus on the suspicion of Wilson's disease. Following a stepwise approach, we measured 24-hour urinary copper excretion, which, although not particularly low, remained below the diagnostic cutoff. In addition, there are no ophthalmologic signs, and nor was there any neurological involvement attributable to Wilson's disease. The Ferenczi score was inconclusive based on this first-line investigation, with a total score of 2, indicating that the diagnosis was only possible. What should be done next, then? A genetic testing or a liver biopsy? In this case, we clearly lean toward performing genetic testing. Genetic testing that in our setting was performed as a trio whole genome sequencing identified 2 variants, a glycine to alanine substitution in position 6 to 6, and the methionine to isoleucine substitution at position 665 in the ATP7 gene. The first variant was clearly pathogenic and has already been described in the literature. The second variant is classifying as having conflicting evidence of pathogenicity because it shows an allele frequency that is relatively high for a pathogenic variant. In silico predictions of its impact on protein function are uncertain. No functional studies are currently available. Homozygous individuals without Wilson disease have been reported, yet affected patients have also been described as compound heterozygotes carrying this variant alongside a known pathogenic mutation. The conclusion is that this variant likely behaves like a hypomorphic allele, reducing the amount of functional protein at the membrane and potentially leading to haploinsufficiency of ATP7B. And as you can see, even Tamara's heterozygous brother shows some alteration in copper metabolism, such as a urinary copper that is not entirely normal, indeed even higher than his sister's, and a borderline ceruloplasmin level. This raises the question, are Tamara's abnormalities in copper metabolism simply due to heterozygosity for a pathogenic variant, or does her specific genotype represent a mild form of Wilson disease? Genetic testing does not provide a definite answer. Therefore, we are compelled to proceed with a liver biopsy. And the liver biopsy ultimately confirms steatosis and demonstrate clearly elevated hepatic copper content consistent with a pathological accumulation. Tamara is therefore diagnosed with Wilson disease in a pre-oligosymptomatic stage, and treatment with zinc acetate is initiated. As shown in the Ferenczi score table, the total score now reaches 5, confirming a definite diagnosis. But I want to stress some physiopathological consideration regarding diagnostic testing. The functions of ATP7B are essentially two. First, on the left, it mediates the transport of copper from the cytosol to the trans-Golgi network, where the metal ion is incorporated into ceruloplasmin. Second, on the right, it regulates trafficking of vesicles containing the transporter protein from the trans-Golgi network to the biliary pole in condition of excess copper, enabling copper excretion into bile. While some missense mutation may selectively impair only the second function, others, and particularly those that disrupt protein transcription, can affect both functions. And another concept is that it takes time for copper that is not excreted into bile to accumulate in tissues and organs and eventually be released into the bloodstream and excreted in the urine. This is supported by the direct correlation between age at diagnosis and levels of urinary copper excretion. This leads to two important considerations. First, as we have seen, some missense mutation even in heterozygosity may be associated with the normal borderline ceruloplasmin level, but more importantly, urinary copper excretion in very young children or in those with mild liver disease may be not markedly elevated. Therefore, in the pediatric setting, the most appropriate diagnostic cutoff is not 100 micrograms like in the adult world, but rather 40 micrograms over 24 hours for the urinary copper excretion. But within this context, the most relevant recent scientific advancement in the field of Wilson disease diagnosis is the recognized diagnostic value of relative exchangeable copper. This is defined as the ratio between the free exchangeable copper and the total plasma copper. So this is the ratio between the copper bioavailable and not bound to ceruloplasmin into the total copper, measured with high precision techniques. If this ratio exceeds 15%, current guidelines indicate that the treatment actually can be initiated even in absence of genetic confirmation of Wilson disease, because the reliability of this test is very, very high. Across different cutoff values, relative exchangeable copper performs very well and demonstrates extremely high diagnostic accuracy, outperforming all other biochemical tests for Wilson disease. Its performance approached 100% for both sensitivity and specificity. Importantly, for the pediatric setting, relative exchangeable copper appears to reach its optimal diagnostic performance earlier than urinary copper excretion, providing a diagnostic advantage in mild phenotypes and in early pediatric presentation of Wilson disease. In our case, relative exchangeable copper was the only non-invasive test able to clearly distinguish between the affected sister from her heterozygous brother, and this increasingly supports the trend and the potential for non-invasive diagnosis of Wilson disease. We are facing now a case of muscled overlap, as Tamara presents clear cardiometabolic criteria and has also showed an improvement in transaminase levels following non-pharmacologic metabolic intervention. However, she also had an underlying monogenic condition, Wilson's disease, which proved also challenging to diagnose. This case also exemplifies the mutual interplay between genotype and phenotype. Genotype helps in interpreting biochemical findings, allows comparison with heterozygous subjects or different genotypes within the same family, confirm the clinical suspicion at its best, in the best case scenario, and it's not influenced by the stage of liver disease. Conversely, phenotype, when thoroughly assessed, supports variant classification, enables dynamic or repeated testing, and helps in the interpretation of copper metabolism parameter in relation to the organ involvement. Briefly addressing treatment, therapy is essentially based on two main classes of drugs, such as chelators and that are dipenicillamine and trientine, and zinc. In many cases, this treatment can be used as alternatives. However, in severe liver disease, chelators are generally preferred, and as well as in acute liver failure. Conversely, in pre-symptomatic patients, like in the case of Tamara, there is a preferential approach toward the use of zinc. Monitoring patients under treatment is also very important, especially in children, because children are not only at risk of under treatment and toxic copper accumulation, but also of copper deficiency. That's why normalization of transaminases is certainly the main therapeutic target, but not the only one. And regularly monitoring of urinary copper is recommended with target range that differ depending on the treatment used. But also in this case, free exchangeable copper can be helpful in treatment monitoring. Considering the case of a child on long-term dipenicillamine therapy with stable urinary copper excretion appropriately ranging between 200 and 300 micrograms, who shows subsequently a reduction in urinary copper levels. In this situation, the key question is, are we dealing with poor adherence or over-treatment? Exchangeable copper can resolve this, as if it's low, below 5 microgram per deciliter, over-treatment is likely. Conversely, if it is elevated, poor adherence should be suspected. Just few take-homes. In pediatric steatotic liver disease, a balance between positive muscle D diagnosis and exclusion of monogenic etiology occurs. A partial response to dietary intervention or lifestyle intervention does not invariably exclude non-muscle D etiology. Think about muscle D overlap in young patients. Wilson disease must be always ruled out, I would say extensively in children with steatotic liver disease. ATP7B genetic testing can be inconclusive, and heterozygosity may explain alterations in copper tests. Copper metabolism tests can be influenced, on the other hand, by the liver disease stage and the age, and genetics and biochemistry come to the aid of each other, and we have explored this mutual collaboration as a golden rule. Let me thank you for the attention, and also just remember the very good times that we had last year in the monothematic conference on steatotic liver disease in Bergamo. Thank you very much.
Thank you, Emanuele. Thank you for this very interesting presentation. And we have all the presentation, and so we can open officially the discussion. I think that was a very nice webinar, because each speaker tried to highlight the message in this focus in relation, putting a relationship, the genetic and the nutrition aspect related to the pediatric steatotic liver, and I think that this was very interesting. So I saw that there is a question from the audience. Regarding protein in the diet, should we just cover protein requirements, or does the study offer a value of how much protein is given in those high protein diets? So I think that is a question for Giulia.
Yes. Thank you. Usually in the balanced diet, when we speak about protein, we refer to an energy intake from protein around 50%.
Julia, we have a little bit of echo.
Usually this is important, but when we create a dietary plan, we focus on population reference intakes are usually written for grams for kilos of the children. So we usually set the target to that specific protein requirements. In the hypocaloric plan that are not superior to a pattern, usually the dietary pattern, usually the amount 30% of daily energy intake, and increasing that much the protein intake, you have to lower the one from carbohydrates around the 30-35, and this is not educational for the children nor for the family. Specifically, it's not possible to follow this in the long term. It's not balanced also in the long term. So there is no superiority of giving hyperproteic and hypocaloric diet compared to standard balanced low calorie ones. So yes, please follow the dietary requirements and prefer for
Okay, thank you, Giulia. There are no other questions. Just before to give the speech to Claudia, in this sense, continuing on the dietary intervention, and I have just a question for Judit, because you showed the first evidence that coming from this initial systematic review regarding the role of the active compounds. But what is your suggestion for the use these bioactive compounds in the clinical practice of muscle management related to obesity?
At the moment, I think that we don't have sufficient evidence behind to recommend routine to recommend the use of any of these bioactive compounds routinely in clinical practice. I think that omega-3 fatty acids and maybe probiotics have shown promising results, but the evidence is still limited. As I have shown, there is the studies are too heterogeneous. There is very different sample sizes, doses, and the duration of the studies. So we need more research on this topic or more evidence. So for the moment, the recommendation is lifestyle intervention, exercise, and maybe we can try to recommend also these probiotics, but helping these therapies with diet and with exercise.
Thank you, Judit.
Thanks.
I don't know if Claudia has some questions.
Yes, thank you, Elvira. Well, I'm very surprised that no one asked for transaminases levels because, well, this question is for Sander, but also for Giulia and Judit, and probably to Emmanuele. Do you believe that transaminase levels change is a good endpoint for clinical study on dietary or pharmacological intervention? I mean, your evidences are mostly based on transaminase or on alt change. So, regarding what Sander explained us, some transaminases only that give you only the opportunity to screen patient with muscle D, but not to focus on the severity of the disease. And in adult patient, transaminase levels are not used as a clinical marker of the severity of the disease. So what do you believe? Is now the time to change this paradigm to find other endpoint for our studies? What do you believe?
Yeah, this is a very good question, and I think you gave part of the answer yourself. So first of all, transaminases, indeed, there is some evidence from histological studies that with transaminase decrease, the liver severity or liver disease severity decreases, but this is of course in selected patients who have probably a high level of disease to start with and probably also have high ALT to start with. But it is not so easy to define endpoints for clinical studies in children. Historically, we have used ALT, and I think this will always remain a part of the outcome because it's so easy to assess. We've previously done a study where we used FibroScan and we used CAP values and steatosis and ultrasound as an outcome, and I do believe in that. But on the other hand, we also don't have a lot of evidence in children that FibroScan decrease or CAP decrease correlates with disease improvement. I mean, it does sound logical, and it would be strange if it were not, but it hasn't been very well demonstrated. And the same basically is true of every non-invasive marker, except maybe MRI, but even there the data in children are very low. So either we use ALTs or we should or almost go to biopsy. But I think we need to do more work in the field of non-invasive tests to be really able to show that if CAP decreases or if FibroScan decreases, that the patient is doing better. But this is difficult to achieve.
And Giulia and Judith, do you believe that the results are real or are really useful for clinical practice? I mean, the results are true, or we need to have more information, more specific results to prescribe those supplements or anything to children with muscle D and obesity.
I totally agree with Sander in the meaning that usually they have been used, but it should be better to complement at least more than one, just to have different possibility to tackle, you know, the condition, and not looking only at the ILT, but also try to use CAP parallel. So try to complement different outcomes parameters. So this might be a solution, and increase the number of studies. Also from dietary perspective, of course, definitely. From bioactive ones, I think that Judit agrees that ALT is not enough to create then a dietary and the supplement recommendation. It's not enough, I think. What do you think, Judit?
Yes, I totally agree. In fact, there are some studies that also assess ultrasonography or fluoroscan images diagnosis, but it's true that the most common is ALT, and we have to go deeper on this, but I totally agree.
Thank you. I have another question for Emmanuele. So, Emmanuele, it is always very difficult to find behind obesity, muscle D, to find the rare disease behind. For Wilson disease, I think is more difficult because the biochemistry and the tests we have are not so really not so precise. So it is very important what you said regarding the free exchangeable copper. I mean, when we use seroplasmin to screen Wilson disease in those patients, you know that seroplasmin can change during, for instance, inflammation. Do you have information regarding the change of the exchangeable copper during, for instance, infections or inflammation or other conditions? It is more precise also in this sense.
Thank you for the question, Claudia. We have data. We launched the test in Bergamo 3 years ago, and we have data on children with acute liver failure, for example, or neurologic disease, and also in patients with mild chronic liver disease. And it is reliable in all these conditions. So I think that it could be a very good complementary test that performs good and performs better in that cases in which the urinary copper excretion performs less better, like for example cholestasis, severe hepatocellular injury, or on the other hand in the early phase or in the youngest patients. So it could be implemented, and maybe it should be studied also on a multi-center manner.
Yes, thank you for your answer. And do you think that urinary copper excretion is really feasible everywhere? I mean, it is not so easy to find a laboratory with a good methods to check these levels of copper.
Yeah, this is a point, and also the fact that collecting a good specimen is not so easy, and also well, but I think it is now at least in many centers it is available. But the problem is the interpretation, because you have to be quite expert. You have to be a trained physician to correctly interpret the urinary copper.
Thank you.
Thank
So
you.
and also continuing this topic, according to that, is a suggestion it's better to evaluate the biomarker of the copper metabolism together, so not just to require seroplasmin level. Is correct?
Absolutely. You have to go in depth every time.
So to require for seroplasmin, the plasma copper and the urine copper together.
Yes. Plasma-free copper. Historically, we used to measure the total copper and to extrapolate the free copper with the formula, but this is not reliable. Now we have this direct measurement that allows a very good diagnostic tool. So I suggest to perform it alongside with ceruloplasmin and urinary copper all the time.
Okay. And I have just a brief question for Sander, because he mentioned that the role of the tools for the fibrosis, because I think that, for example, regarding the evaluation of fibrosis, the presence of the scan, the FibroScan, is not worldwide, is not present in all the health hospital. And we know that there is an increase of obesity, an increase of metabolic alteration related to obesity, an increase of fatty liver in
Elvira, you are
Elvira,
freezed.
we cannot hear you.
You are freezed.
Okay, Sander, start to answer because the question was quite complete.
I'm not sure exactly
what do you suggest to have
Oh. Sorry. So the question was on FibroScan? Yes. So the question was on FibroScan, but exactly what?
We didn't hear.
Okay,
the
sorry,
complete
probably.
answer.
Yes, I had a problem on connection. No, the main answer is, do you suggest a FibroScan tool in case it's not possible to perform the FibroScan because you know that the FibroScan is not present worldwide, and while there is an increase of fatty liver involvement in children with obesity. So what type of tool you suggest to use, or none is useful, because as you showed there is no efficacy accuracy.
Yeah, it is difficult and it is a problem. So the guidelines still recommend using ALT and staying for the moment with that, using ALT, using gamma GT, looking at, as we discussed just 5 minutes ago, at the evolution over time. We and an American group both have made new risk scores. So if they are validated, that is something you can use, because for both scores, there are calculators online that you can just fill in some data. And both of them also include ALT. So, but except for ALT, they also include some measures of weight, some measures of perhaps metabolic comorbidities. And this makes sense because the more metabolic comorbidities they are, the higher the weight, the higher the risk of fibrosis is. So this is just reflecting that. So either you try to use a score like this, or you rely on your clinical reasoning in the sense that you use ALT, but you also keep in mind, okay, this is a child who has insulin resistance, who has maybe sleep apnea, who has hypertension, then the risk of fibrosis gets higher and higher. And at some point, then you try to see, okay, should I refer this child, or what should I do with the child? And for the risk score that have been developed, we are now starting a project where we are trying to prospectively validate this in a kind of general pediatric obesity setting, to help perhaps physicians see, okay, who of all these patients should I refer, and who of the patients can I manage myself. But at the moment, if there is no FibroScan, you can either try to use these, but the evidence is still a bit lacking, or you rely on ALT, but of course that's also not ideal. So there is a big gap there. Yes.
Okay, thank you. There is a question from the audience. do you have experience with treating fulminant hepatitis in pediatrics? And what should be protein restriction when we talk about a 6-year-old child whose clinical picture is worsened with encephalopathy? Are there recommendations?
Well, I start, but I invite all the faculty members to take part in the discussion. I think that in this case we are more dealing with the neurological impaired children, so we will have to take into consideration different aspects of dietary management. It's not just a condition related to liver, but there is also neurological impaired, and probably might be also artificial nutrition. It's much more complex. I don't know whether the faculty wants to add more maybe on hepatitis directly.
Emmanuele, do you want to add something to this reply?
Historically, a protein restriction was used in adult studies to reduce ammonia. However, there is no recommendation that it is useful to prevent encephalopathy. It can induce sarcopenia, and muscles are a site for ammonia detoxification. So we don't have to focus on ammonia, which is the only toxic that is measurable, but there are many toxics, and we cannot do what is not recommended. So we don't use it in clinical practice.
We can reply that in case of fulminant hepatitis and there is a neurological impairment, obviously it's important to test the ammonia level.
Yeah.
And if the ammonia level is very high, we recommend to stop the protein intake for the moments.
But we have to tackle encephalopathy in many other ways, such as ammonia scavengers, lactulose and also fluid exchange.
So waiting, I think that I don't know what the audience question, but in general, I think that if we have a child with fulminant hepatitis, so I think a high level of transaminases, and there is a neurological impairment, obviously that we have to think to the biochemical evaluation related to the neurological impairment, and so to test the ammonia. If in case the ammonia is high, to stop the protein intake, to use drugs for reduce ammonia. And in meantime, we have to complete the evaluation for further evaluation, obviously in this case, probably related to inborn error metabolism, but also other type of involvement. I think that we can...
This is in the case of a very young child with a suspicion of a metabolic disease. Okay, this is another case, yes.
I don't know if we have the time for another question, but moving from acute liver failure to our topic. I have a question for Giulia and Judit. Do you have any information regarding the hyperproteic diet in those patients? I mean, you know, this is something that is that it gives some concern, because a lot of adolescents start a hyperproteic diet without any clinical consultation. So what do you think? Do you have any experience or any data on this kind of intervention?
From the literature, there are no studies in children and adolescents with MASLD comparing specifically hyperprotect diet to standard. The evidence I've showed you for the recommendation is mainly based on obesity, so standard childhood obesity consensus statement, because we know that in obesity, of course, it's not recommended, and there are several studies in childhood obesity, not specifically in muscle D of adolescents. However, I fully agree with the childhood obesity statements, which means that these hyperprotect diets are not recommended. And sometimes it happens during consultation that specifically children, that adolescents that start, for example, gym training and similar, they trying to implement their physical activity. They also start also using amino acids, soluble amino acids, and they also include much more protein into their diet, but this is not recommended. And we always, during our clinical visit, try to discourage this intake, because when dealing with pediatric age, there is no need to go for that diet with the hyperprotect content. I don't know whether Judith want to add something.
Yes, but I think that we have to conclude to finish the webinar because we have no more time. So I want to thank the speaker and the audience. It was very interesting to speak about the role of nutrition and genetics in pediatric liver disease. I want to thank also Claudia for sharing with me and give her the final hello.
Thank you.
Thank you.
Bye-bye. Thank you so much.
Bye-bye.
Bye-bye.
Thank
Bye.
you. Thank you so much.
Thanks. Bye.